to share. Anna. How did the preachers do? Yeah. The preachers, how did they do?
It's hard.
Oh, too bad.
It's hard.
It's hard.
Yeah. It's PhD.
That's good. In fact, don't you say the person, I'm not fine. Seriously, true.
Is it live?
I don't know.
Let me check.
To go about this. So, when you attack them, they say the person. Okay, so we're supposed to be discussing DLS. DLS, my name. So, yeah, I'll need to know your name so that.
Your name again?
Hector.
Normally,
I don't mention my surname, I mention my face, I'm just spamming and never. Yes. Okay, so you can mention your face in only your face. Okay. But I remember when I was going to register my son, not my son, just my daughter, she was very confident. She said, those times, they were very fatty. They say it's also not with you, very discussion. George. Kingsley. Someone. This man, I know him. Red, yes. Gilbert. Sarah. Gerald. All right. Nice to meet all of you. So back to DLS. Basic life support, isn't it? Good. Basic life support. What is the main component of basic life support? Same thing, but it's not come down. CPR, good. How many of us have gone through the DLS before? I usually have not gone through. Something like that.
Yeah, some years ago.
Oh, nice. So those would be my co-pilots.
No. Do you know what? I tried to remember the question, the pretense.
Right.
Could you remember?
You faded away.
I couldn't.
Yeah. Times when you don't do something,
Yeah.
Use it to visit it. Once you don't use that time, it leaves you. But once you mention it, it comes back. Okay, so it's cardiopulmonary resuscitation, and then the CPR, cardiopulmonary resuscitation. So those two main words in there, cardiopulmonary. What does it really mean? Cardio is what? Heart, and pulmonary is what? Lungs. So it's basically resuscitating the heart and the lungs. That's basically what it is, isn't it? Resuscitating the heart and the lungs. That is cardiopulmonary resuscitation. So the question is, who would need for you to do a cardiopulmonary resuscitation on? You need to do CPR. But do you do CPR on anybody you find around? Or there's some particular patients? You may be in the radiology suite and then someone comes and comes to do an imaging. They come and something happens to them. And you need to start CPR. What would you see, or what would be the indication for you starting that CPR? What do you think? Okay, difficulty breathing. Okay, all right. We'll consider that. Come back to it. You were saying something.
You observe the patient, so in the line of duty starts the group or that is changing, or any kind of patient is changing, then you have to be extra careful because you don't know what exactly is happening.
Right.
It is then that sometimes you realize that the patient is not responding or the thing is even about falling or is even losing breath or something like that. So you just have to observe the patient and see there are any changes.
Okay. So you said you need to continue monitoring, looking out for the patient. Okay.
Sometimes the way they transport the patient, there's
choking with no pulse.
Okay. Okay. Okay.
Yes, that means that behaving different.
Sure.
That's no for.
Okay, so he's mentioned choking as one of the things that probably made requires. Okay, any other? Please, at this side. Okay, let me put you. I'll come back to
When you have a patient who is suddenly unresponsive to,
Oh, is it somebody there? Oh, there's somebody there. Wow. Is the person coming? Will the person come?
No.
Not now, eh? Not now, then he can occupy the seat now. Nana.
yeah.
Then, yeah, you can sit there now. When the person comes, the person will be with me. Okay. All right. Sorry.
I was saying when you have a patient who is unresponsive to you suddenly,
Okay.
then you can monitor the patient. If you don't feel any pulse and there's no breathing, then you can start it.
Okay. Okay.
Actually, it's quite similar.
Similar. Right. Okay. So you see that if the person is unresponsive, does not have a pulse, it's not breathing, then you need to start that. So we do cardiopulmonary resuscitation on patients who have cardiac arrest and or respiratory arrest. Cardiac arrest and or respiratory arrest. Okay. Now we'll come to see the things that we look out for to see someone is in cardiac or respiratory arrest. Okay. But before we get there, what do you think? Is the difference between, or is there any difference actually, between cardiac arrest, heart attack, and heart failure? Any difference between those things? Yes.
Heart failure.
Cardiac arrest, heart failure, heart attack. The same thing. This group. Any voice from here saying anything different, or we support them.
There might be difference.
There might be. So what are the differences if there are?
So heart failure,
Mhm.
I think it's when there's no pulsation within around the coronary arteries of the heart.
You are talking about the heart failure. Okay. You say when there is no pulsation around in the coronary arteries.
Yeah.
Okay. All right.
And
Okay.
heart attack is when it's there might be difference, but I'm finding it difficult to figure it out.
Okay.
Yes.
He thinks there might be some difference, but it's not clear in his mind yet, but he thinks that there might be some. Okay.
Heart attack.
Mhm.
That's supplied to the heart disease.
Okay.
Heart failure.
Mhm.
That's what
Okay. Then what about that? Cardiac arrest. It's about the heart attack. Just tricking your minds away. Trying to trick your minds away. Okay, so
Which one?
as he said,
I don't
the heart attack, which is also we call the myocardial infarction, is an infarction. So it means that blood supply to the part of the heart is not going. So there's a blockade or a block in the coronary arteries. So this cytokine cholesterol and all those things, they deposit, they block the thing, and they get a heart attack. That's when they come and their chest is pain. But their heart is beating. But just that they have a chest pain because, like, people have muscle pull. Running very fast, blood supply, demand supply, there's a mismatch there. You don't get enough blood going to the muscles. You get a muscle pull, that ache that you get. It's the same thing that the heart gets. When enough blood is not moving to some part of the heart because there's a blockage in the arteries. That would be a heart attack, and that's the same as myocardial infarction. Okay. So that is also different from heart failure. With the heart failure, the function of the heart is not optimal. So you're supposed to pump, beat well, pump, and get blood out of the heart into circulation, right? It's not able to do that well, and some of the blood stays back, gets backlogged in the lungs. They get this pulmonary edema. They are short of breath, and at times it goes all the way, and then they have edema of their feet and all that. That will be heart failure. They are sweaty and all that. That is the heart not working well, and then they feel that. Okay, so that's a bit different from the heart attack, which is the blockade in the. I know some of these ones. Some of them lead to the other. So the heart attack, for instance, if a part of the muscle of the heart is dead, it won't function well eventually. Then it may lead to heart failure. So it may lead to that. Okay, but there are so many other causes of the heart failure, which if you have an arrhythmia, the heart is beating abnormally, it can also lead to heart failure. Okay, so it's different. The heart attack is different from the heart failure. And it's also different from cardiac arrest. Arrest means cessation, it has stopped. The heart is not beating at all. If the heart is not beating, you are what? Exactly. So cardiac arrest is virtually someone who has died. That's what it is. The heart has stopped. Okay. So there are differences in the breathing. Bringing it to this is about the heart. When we bring it to the lungs, we can also have a respiratory arrest. We can have respiratory failure. Okay. You can have respiratory arrest. You can have respiratory failure. So if you just extrapolate the same things that we're talking about, the respiratory arrest will be that there's no breathing. Okay. And respiratory failure is that the lungs are not working as well as you want it to be working. Okay, so the lungs basically is involved in getting in oxygen and getting out carbon dioxide. If there's a problem with that, you are having respiratory failure. Okay, so there are two types basically of respiratory failure, type 1 and type 2. Type 1 deals with oxygen, type 2 deals with carbon dioxide, basically. So if your oxygen levels are low, oxygen levels are low and low, they are type 1. Anytime carbon dioxide starts increasing, they are in type 2. In type 2, oxygen levels may be normal or low, but carbon dioxide is up. That's the most important thing. It means that carbon dioxide, when you see carbon dioxide bit is more about ventilation, being able to move in gases in and out. So if someone is having a ventilation problem, the person will require for you to intubate them and stuff like that. That is type 2 respiratory failure. We're not talking about respiratory failure, where they have oxygen issues or they haven't come out of issues. What you're talking about is respiratory failure, when they have ceased breathing. Okay. I hope you are on the same page now. Are we? So we are talking about cardiac arrest and respiratory arrest. Those are the things we are talking about. Okay. Those are the people who would need for us to do the cardiopulmonary resuscitation, because we are resuscitating the heart and the lungs, and they should have been in arrest for us to resuscitate. If the person has a pulse, you do not do cardiopulmonary resuscitation. You don't do compression.
Pre-test.
There's nothing in pre-test. Oh, seriously, I don't know what's in the pre-test too. Seriously, I don't know. So if someone is having a pulse, you don't do compressions on them. Because we'll come to understand that the compression is technically taking control or trying to do the beating of the heart. Temporarily trying to do the beating of the heart. That's what you are doing by compression. So if the person has a pulse, you don't do it. Okay. So if the person has a pulse and is not breathing, so with that you don't do the compression, but you help them to breathe. That's how it goes. Okay. So that is what it is, and we need to be on the same page. Now, when it comes to the BLS and ACLS and all those, it's the American Heart Association that put together the course. Okay. And for them, they've divided everybody into whether you are an infant, you are a child, or you're an adult. Okay, so they have age groups to classify them. Okay, so if someone is less than a year, but more than 1 day old, the person is classified as an infant. That's how they are classifying us. So an infant is day 2 to 1 year. First day is a newborn, and the approach is totally different. The approach is different. Okay, so they are different. But we are considering day 2 to 1 year. That's what we are looking at. Okay. Sorry. And from 1 year to puberty is what they are calling a child. And the puberty they are looking at. Sorry. Okay, 1 year. About 1 year to puberty. The puberty, they say that a male with hair in the armpit and hair on the chest, around 12 years is what they are talking about. And a lady developing breast will be a puberty. So that's up to like 12 years, thereabout. Okay. And then after that, you're an adult. After 12 years, they classify you as an adult. So if you look here, this would be an infant. This one is an infant. Okay. And this one here will be a child. And this will be an adult. So the mannequins are like that. And the reason why they classify them is the approaches are slightly different between the ages. What you do is slightly different between the ages. But I want us to know about that also. That's what you will do. I'll bring out some of the differences as we go along. Okay, but most of the things are the same. Okay. So, any questions so far? We're all good. Okay, all right. So how do we identify someone to have the cardiac arrest? Okay, when do we identify that someone has a cardiac arrest? And that's what he mentioned earlier on. So the things you look out for is that the person is likely to be unresponsive. You cannot stimulate the person out of, I don't know whether they are sleeping or whatever it is. You can't stimulate them out of it. So the first one is being unresponsive. So unresponsiveness is one of the first things that we look out for. Okay. But we don't end there. Because it could be that the person is unresponsive because probably he has a stroke and is in deep coma. But he has a pulse and he's breathing. But he's unresponsive. So such a person, yes, we've identified that the person is unresponsive. But we'll go on further to identify other things to say that the person is in cardiac arrest. Okay. So the person is unresponsive is one of the first things. And we also check whether the person has spontaneous breathing. Are they breathing by themselves? Okay. So we look out for how we examine to see that the person is breathing by themselves. If the person is not breathing, it could be that they are not breathing, but they have a pulse. And with that, if they are not breathing, but they have a pulse, we'll not do the compression, but we'll support them to breathe. So we'll go on the third to examine whether they have a pulse or not. So if we check, this person is unresponsive. The person does not have a pulse. It's not breathing and does not have a pulse. Then we'll go ahead and do the compression for the person. Do we get it? So it's a stepwise thing that we do. First check for responsiveness. You check for breathing. Then you check for a pulse. Okay. I've already said that you can have someone who's not breathing, but they have a pulse. Can you also have somebody who's breathing, but they don't have a pulse? The person is breathing, but he doesn't have a pulse.
Not sure.
Sorry.
Not sure.
Sorry.
It's not possible.
Yeah, that's not possible, isn't it? Yeah, it's not possible. So the person does not have a pulse is walking around breathing. It's not But the other way, where they are not breathing but they have a pulse is this. What conditions can give you that? Where there's someone who is not breathing but they have a pulse. What can result in that? What can result in that?
This is not breathing.
Yes, but they have a pulse. What can cause that? They are still breathing. But then they have difficulty breathing. Abdomen. Yes, but that's yes. If you obstruct the airway, they breathe, but it's difficult for the air to go down. Sorry. They have both pulse and they breathe. Then they pass out and they come back by themselves.
Semi-conscious.
But they still breathing. It's drugs that can do that. But what particular drug can do that? Okay. The heart rate goes very high, goes very high. There are people that are dilated. Yeah. They still breathe. The opioids. Opioids. So morphine, tramadol, Petidate, those things. So those people were dying from tramol. And that's how they were dying. It will cause a respiratory arrest. And subsequently, if you don't get oxygen getting into you for some time, your heart too will stop eventually. That brings me to the next question that
So you're saying they are
They have
breathing,
to.
but then
no, they are not breathing.
but there's pulse.
Yes,
Go online watch.
yeah, they are not breathing. But the opioids can affect
Yeah,
respiratory
I'll go.
centers and depressants, so that you don't breathe. Yeah. How long after an arrest, cardiac arrest, would your brain die irreversibly? Mm-hmm. 10 minutes, option 1. 6 minutes, option 2. Any other? 3 to 4 minutes. 3 to 4 minutes. So once you don't perfuse your brain, because the cardiac arrest, that means that you're not perfusing, isn't it? No blood is going into the brain. So within that time, 3 to 4 minutes, if your blood does not get oxygen, 3 to 4. Yes, the brain will die irreversibly. You may get the heart coming back, and the brain is dead and it's gone. Yes, I mean you can have yes, the brain is dead, and you can put you on a ventilator for years, but your brain is gone. You can't do anything, and they call them vegetables. Yeah, vegetative states. And that's it. You can't function.
Has there been anything where there was a reverse?
I've not heard, and I know that some people have not ventilated for years. And after some time, they decided that okay, let's.
I have a friend who is on it for 6 years now.
Okay. Wow. Is he in Ghana?
In the UK, there's a debate as to
It's only there that you can have this opportunity. You don't have enough ventilators for you to occupy one, unless you buy a home and you are home with it. But in the hospital, no one will do that. You don't have enough for you to come and occupy one, and you are just on it. Others are dying. Exactly. Yeah, but eventually they die. Yeah. Oh yeah. As you say, someone for years. Okay. Yeah. So once the heart is still there, we can't say you are dead. Okay. But we'll say that the brain is dead. Okay, we will say that the brain is dead. Okay. So it means that time is of essence when it comes to people having cardiac arrest and all that. And that's how come we may not be taking care of the patient that much. Maybe the radiologist shoes, but we still need to know how to do it because when it happens, you're not leaving the radiology to go look for the doctors or the nurses to come and do it. You need to start something and call for help. You get it? So that's why we need to know. Within minutes, the brain is gone and gone forever. Okay, so we need to act quickly. So we've talked about the things that we need to identify. Unresponsiveness, no breathing, no pulse. Okay, so that's what we will need to examine on the patient to know. So as you are saying, as the patient comes and they are transferring the patient, they are monitoring the patient. A patient who came conscious, now all of a sudden, no movement at all. Then you start going through the processes. The patient responsive. How do you check for responsiveness? That's the next thing I want us to look at. But when it comes to, let me just say this one. When it comes to cardiac arrest, the approach that we use is, before we were doing ABC, when we look at airway, breathing, circulation. When it comes to cardiac arrest, the C comes before the A. So we do CAB. And the C, which is starting now, is not circulation. I mean, it goes with circulation, but it's more compression. So the C is a compression. Then it comes to the airway, you assess the airway, make sure that the airway is patent. Okay. Before you B comes in, giving breaths. Okay, that's breathing for them. And it makes sense, you didn't get it right. So we are saying that every time any emergency, we say A, B, C, D. Basically, that's emergency. A, B, C. But when it comes to cardiac arrest, it's not A, B, C. It's C, A, B. And the C is compression. A is the airway, making sure that it's patent. And then B is breathing. That's giving them the air, basically oxygen. So that's the approach, and that's the approach that we'll go. Okay. And actually, I didn't say the D. So it's CAB, CAB, D. D will be defibrillator. Hi. Welcome. Defibrillator. Okay, so we'll start with the C, which is the compression. But first, we need to assess that the patient has a cardiac arrest for us to start the compression, isn't it? But any time you approach any patient that you suspect to have a cardiac arrest, you need to ensure that the scene is safe. Okay, the scene has to be safe. Let's say after this meeting or after this training, you say, oh, now you have BLS training, you have the skills. The way going on the road, someone is in the middle of the road and in the middle of the road now, so you sure that's why I second patient. You don't want any second patient. One is enough. One is enough. So every time you need to ensure that the scene is safe. Ensure that there's no fire, there's no electrical thing. You got a cardiac arrest from being electrocuted. So you must be sure that the scene is safe. Okay? The scene should be safe. Alright, so scene safety is the first thing. Ensure that there's no danger. Okay. Then when you check for the scene safety, then you come and check for responsiveness. So I come to this man, I ensure that the scene is safe. And just check for responsiveness. Okay. If I suspect that this man is having or is in cardiac arrest or anything like that, then I'm coming to assess, checking for responsiveness. This is the time I come to stand here and say, go. No. If it's necessary, don't mind. You need to stimulate him to be sure that this man is really unresponsive. Okay. So if this is the guy, then I come, call him, say Kofi. if I hit you like this and you don't wake up, that means you are dead. It means that you are unresponsive. Okay, so that is the way I'll check for responsiveness. Okay, so I check for responsiveness. He's not responding. He's not responding. The next thing I need to do is what? He's not responding. Sorry. Check the breathing, and then we will check for the pulse. But because this man is unresponsive, whatever I need to do from here, I need help. Whatever I will do from here, I will need help. So I need to call for help. So once I've come, I've checked for scene safety. I've checked for responsiveness, not responding. I call for help. I call for help, nearby help, and then I will also require an ambulance to come, especially if it's outside the hospital. If it's in hospital, you call for help, and then yeah, the help should come. Elsewhere, very civilized places.
Just press on the emergency button.
Yes, you just press on the button, and the bell will go, and they will know in which room then they should come, isn't it? But here, deep and bro. To be the bell, that will ring. Everywhere.
I'm gonna say, emergency.
That's what will happen. Okay, so
Go to all the
you are calling for help.
doctors
You
who
will
are
also
supposed for
want,
emergency.
if it's outside of, you want the ambulance to come because they need to transport the business. So you want the ambulance to come. What number are you going to ask them to dial?
The international television.
For the ambulance? Sorry. 192, 193,
The international television.
911.
That's what we are trying.
Sorry.
We
911.
are putting all those things.
You call the number, you say on your phone.
So call in for them to dial. Now you say call in for them to dial. Okay, all right. So I mean the 193 is the ambulance number. So 191 police, 192 fire, 193 ambulance, 191 police service, Ghana police service, and 192 fire service,
PA.
and 193 ambulance.
Abbreviation PA.
193. It used to be that this one, but now on the ambulance you see 112. That's what is on the ambulance now. 112. That's what is on the ambulance. So if you say 193 or 112, it will be correct.
So, sorry, what's the correct answer?
I don't know what is the greatest. When it's 193, that's the answer. 911, it will be nice. Yeah, it will be nice. Yes. You see what Jose Mourinho has done to us? They have watched their movies and they've been mentioning it, so that's what's in our head. You get it? That's the approach.
We should do our own
They
movies.
put the thing in the movie, they put it everywhere, so that people would know it. People will know it. Whether in a country or not, you know it. At 1, 2, up to 11. You see, those are the ones that we would show. Even in hospitals, when we are showing things, it's a before the idea they will show on our televisions. At times when I look at it, I wonder. We have a hospital, no? And before it is even for and the person is sick. Okay, so you ask them to call that number, and you're asking for the ambulance to come. Yes, they will transport the patient right to the hospital. But what one thing do you want them to come along with? One thing. Oxygen option 1. AED option 2.
Bag mask.
Sorry.
The mask.
Okay, the bag mask device option 3. Oxygen, more staff, more personnel. The one thing that you want is the automated external defibrillator. Automated external defibrillator. That is the most important thing that you know. Because remember we said that CABD, isn't it? A D, a defibrillator. You need them to come along because that one you don't have it there. You don't have it. Okay, so you have checked for the scene safety. The scene is safe. You've checked for responsiveness. The person is not responding. You've called for help. You call for the ambulance. The ambulance is on its way. How long will it take the ambulance to get to you? 10 minutes. Will the ambulance get to Ghana?
2 hours.
Oh, okay. Good.
They are not running the head office.
Yes.
Give them who are-
I'll agree with that. So, but I've seen studies where they say that their response time is 6 minutes. Yeah.
Maybe they are whole or this-
It's 6 minutes. So that's how soon they say they will get to us. So they are coming. By this 6 minutes, we can't wait. So we have to do something. So what will we be doing? If the person has a cardiac arrest, as we have identified, okay, so we've called for the ambulance coming, but we just assess up to responsiveness. We haven't gone further. So once they are coming, we need to establish whether this patient has a cardiac arrest, isn't it? So that we know what to do. Okay. So we need to check for breathing. And how are you going to check for the breathing? Sorry. Yes. So you look on the chest, whether there's chest rise and fall. Okay, you look. So this one you look. And ideally you need to expose their chest. Okay. So if you check for responsiveness, they didn't respond. Call 193. They are doing that. Then I expose his chest. Then I look. As I'm looking, I can also feel whether he's breathing. I'm bringing the dorsum of my hand over his nostril. Okay, so I'm looking, and I'm looking and also feel.
Look and feel.
Okay, look and feel. So I see no chest rise, but they are saying that you should spend within 5 seconds to 10 seconds to determine that this patient is in cardiac arrest. So I can't spend all the time trying to put my dorsum over and looking and I'm there. 10 seconds will be over. So whilst one hand is checking for the pulse, I'm looking. So I'll be doing 2 things at the same time, so that I can buy time. All right. So I'll need to find. We will come to that. I need to find a pulse. So whilst my finger is on the pulse, I'm looking. If there's no pulse, I'll know that there's no pulse. If the chest is not right, I'll know that the chest is not right. And not more than 10 seconds, I should determine that this patient is cardiac arrest and you need compression. Okay. So you look whilst you palpate for the pulse. Okay. But still, I mean, the other hand is there. You can use the other hand to check, to feel. So this one is doing that. This one is over here. You are looking. Isn't it? Yeah. So you can do that. So he's not breathing. That's another. He's not breathing. And for the pulse, where do you check for the pulse? So since we talked about responsiveness, you go the infant and you go the adult and the child. That's how you assess them. For the infant, you tap the sole of their feet. Check for responsiveness. Because I go pay. I can also do. So you tap the heel to check for responsiveness, basically. Okay, so they're checking for the pulse. Where would you check for the pulse?
Carotid artery.
The carotid is one. The wrist is an option. We'll come to that. Any other place that you check for the pulse?
That day, right?
The femoral pulse. So when you are checking for the pulse in someone who has a cardiac arrest, you check for the central pulses, not the peripheral pulse. And the radial, the wrist area one is a peripheral one, which you can't rely on. So you check for the carotid and the femoral. But usually because if you are one, because you are more towards the head end, you check for the carotid. If you're in hospital and you have so many people, then someone can also check for the femoral. So that's where you check for the pulses in a child and another adult. When it comes to the infant, yes, please.
I have to ask you because you introduced the thought that you can involve another person.
Yes.
There's a school of thought that in instances like this, it's not advisable to involve another person. What's your take on it?
Oh no. So actually the course talks about one rescuer and two rescuer. Anything more than one is considered two. So you have one rescuer. If you're alone, the kind of things you can do. And if you are more than one, the kind of things you can do. If you are more than one, it's always better. And that's how come you even call for help. Other than that, you can't power it. When it comes to the compression, that's when you see that Charlie, this is not one man job. No.
Muscles.
It's quite tiring. So the more the people, the better. But then you don't let the place become so crowded. People not knowing what they are doing. They are also more hacking. I'm the child one name. Over Hannah always say, "It'll be a managing." No, you don't want that. There should always be a team leader. Okay, everything will be routed through that person. And so we say, "Oh, wait, no, it all goes to one person." Okay, so you suggest, team leader, should we consider this? Then you give the order. Let's do that. And so we are committee. Okay. All right. So. Checking for the pulse in the infant. Where do you check it? They say you check for the brachial pulse in the infant. And where is the brachial pulse in the infant? They say that it's in the it's medial and lateral aspect. So medial aspect of the arm. This is the forearm, isn't it? This is the forearm, this is the arm. Okay, so mid-arm medial aspects of that. So it's somewhere over here. That's where you're going to check for the brachial pulse in the infant. Okay. So this infant, this is the arm. Mid is here, inner aspect inner aspect is over here. So that's where you place your finger to check for its pulse. Okay. That's for the infant. Evaluating them and doing all that. Everything is very small. Anything. Anyway, so that's how we check the pulse in them. So you've checked seeing is safe. Check for responsiveness. It's not responding. You've called for help. Help is coming. Now you've checked for the breathing and you've checked for the pulse. And once you did that, you noticed that, or you came to the diagnosis that this patient is in cardiac arrest. So then what do you do next? Now you diagnose cardiac arrest. What do you do next? You do compression, isn't it? The heart is not working. You want to take control of the heart and you do the compression. Okay. So like compression, how do you go about it? How do you do the compression? How do you do the compression? That's what you need to do. You need to first identify where your hand will go on the chest. Because the hand is going on the chest, not any other part of the body. And the chest too is big. Okay, it's big. It spans all the way. So where exactly on the chest should your hand go? They say that it's in the lower half of the sternum. The lower half of the sternum is where your hand is going to go. The lower half of the sternum. So if you took this mannequin, okay, the lower half, so this from here to the sternum, okay, this is all the sternum. The lower half of it, so that means that we need to divide it into two. What they've said is that you can use the nipple as an imaginary line. You draw where it intersects with the sternum. Your hand can go there. Where it intersects, your hand can be there. Okay, that will be part of the lower half, basically. Okay,
Is that the same as the 110?
sorry.
Is that the same as the 110?
No, it comes to the 110. So the lower half of the sternum, that's what you may do. But it looks like this one we can do it only for males, isn't it? We can't be very sure. Just females. So 3 finger breaths above the xilisternum. You can also use that. So my 3 fingers above the xilisternum, where it comes. So 3 finger breaths, it meets about here. So it's almost around the same point, basically. Okay. So that's where our hand is going to go. So which hand is supposed to go there? The dominant heel. Not the hand actually, it's the heel. Not the palm, not the fingers. It's the heel of the dominant hand. So if you are a lefty, your left heel is what will go and you support with the other one. Okay. So for me, I'm right-handed. So my dominant heel goes there like that. It's not my palm. It's not my palm. It's the heel. Okay, that's what will go there. Then I support with the non-dominant one. Okay. Then I lift it up because the heel I wanted to press. Okay. All right. Now I need to press. I need to press. But I cannot be here and I'm doing compressions. It won't work. Too far away. I need to be well over the patient. My shoulders over the patient. Okay? And my dominant heel is there, like that. And I need to press. That's what I'm going to do. Okay. The question is, I need to press. How deep am I going to press? And that's when the 1/3 comes in. Okay, so the differences are also there in terms of the ages. So if you are an infant or a child, they talk about doing 1/3 the anterior posterior diameter of the chest. So this is anterior, this is posterior. So going deep like that, anterior posterior diameter of the chest, you do 1/3. You do 1/3. A child or infant. So those two age groups. You do 1/3. Now for the infant, they also say that you do about 4 centimeters deep in terms of length. I know the question on your mind, but you don't ask it yet. How do you measure it? Nobody does that. Nobody measures it. Nobody measures it. But so okay, you let me finish that. I'll come back to it. So for the infant, you do about 4 centimeters. Infant. For a child, you do about 5 centimeters. And for the adult, you do at least. You see that at least 5 centimeters, but not more than 6 centimeters. So for the adult, about 5, not more than 6 centimeters. For a child, about 5 centimeters. And for an infant, about 4 centimeters. But for the child and the infant, they also say about 1/3 the anterior posterior diameter of the chest. Okay. And the child is about 5. The adult is at least 5. No, not more than 6. The reason why they say not more than 6 is that if you did more than 6, you cause a lot of injuries. You can cause a rib fractures. Okay? And once the rib is fractured, you can get an immobilized. You can get cardiac contusion. That's what they say. But usually we don't press that deep enough. That's what they've noticed. That we don't even press that deep enough. My ribs breaking there, it happens all the time. Okay? Especially those elderly people. My ribs are brittle and all that. So we have our one. Yeah. So do excavation. Yes.
So the 5 centimeters in inches is 2 inches.
Yes.
Okay.
Yes.
I saw it in there.
So 2 inches. And one of more. I don't see why they are talking about 2 inches for us. But I mean, just so that you know, it's the same.
That's for the adults.
Yes, that's for the adults. So, as we are saying, nobody stands there to see. This chest is 2 centimeters. Nobody does that. Nobody does that. But they have devices that are able to let you know that. So all this we are saying, or what we want to say is that there should be a high quality CPR. And these are the things that they are looking out for to say that it's high quality. So there are things, devices that would let you know that what you are doing is high quality. Our mannequins don't show, but some other mannequins, when you're doing it well, you have these green lights that will show. If you're not doing well, it's red lights that will show. Yeah, it's red light that will show. But in the real life situation, there are things that they connect the patients to tell you whether you're doing it well.
Yeah.
Yeah, in real life, that's what happens. You're able to tell. And
Can I-
for even if you don't have those devices, as I was saying, if someone puts their hand on the femoral pulse, okay, and you do the compression, it's a good compression, they feel the pulse. Anytime you compress, they feel the pulse. If you're not doing well, they won't feel no pulse. Okay, as I said, it's a high quality thing that you're looking out for. To be sure that you're moving the blood from the heart to the brain to the other parts of the body. Okay, so if my hand is on the femoral pulse and I can feel the pulse going to do the compression there, it means that it should go into the brain as well. And that will go into the heart. Because what you are saying is you are buying time whilst you are doing the compression for the heart to kickstart by itself. If you don't get blood going to the heart, which also needs blood, it will not come back. Because it also needs the oxygen and the food and everything for it to start working again. So that's why you need to do the hypothesis. All right. So we've seen where our hand will go. We'll see how deep we are supposed to go. How fast should we go? There's the next question. How fast should we go? Either you do one, you pause, you do another one, and you pause. Yes.
On our hand, is it important to bring organ to be at the patient's left or right?
No, it's in the center. It should be in the center. It should be in the center. Because the more lateral you go, whether to the left or to the right, the likelihood of you causing the refractures. Because now your hand is on the ribs, and I'm going to compress on the ribs, and you break them. So it should be in the center, the stem.
Sorry. I think I also relate with her question. Looking at the
Anatomy of the
Yes.
heart. It's more towards the left.
yes.
So that's what we know. But they say that it shouldn't be the case. It shouldn't be the case. When you do the compressions, what you do is that you would press that whole area. It affects that whole area, and by so doing, blood. Let me demonstrate with this one. So yes, though the heart is more towards the side, when you press, it affects the entire thorax basically. It affects the entire thorax. And when it happens like that, blood, which is sitting in this thing, let's say this is the heart, with blood sitting in it, and this is the arteries, some to the heart itself, some to the brain, and to the rest of the body. Once you do the compression, the heart goes down, blood is squeezed out, it goes into the brain, it goes into the heart. You release, so I press and I release. It's filled with blood again, and it moves. That's basically what you're doing. You're buying time to do. Okay, so you press, you do as you are doing, then the blood is moving back and forth. That's what's happening. Now you have done the compression, like I've done this compression. If I don't allow the heart, the chest, basically, so the chest should recoil. If the chest does not bounce back, the heart will not also bounce back for it to be filled with blood again. So I press and I'm still there, and I press again. There's no blood to move around, isn't it? So it's very important to allow the chest to recoil. So allow the chest to recoil is the other part of the thing. And as much as possible, you minimize interruptions. So when you do the compressions, you do the compression to a certain point to build a particular blood pressure that's able to perfuse the brain, the heart itself, and the other organs. Now, if you do 1, 2, you don't get to that pressure, then you stop. Come down to down 0. Then you start doing it, then you stop. Come down to down 0. So you need to minimize interruptions. Some people do 1, 2, 3. Oh, let's check whether the pulse is back. No, that's not how we do it. That's not how we do it. So they say that you do 30 compressions and you give 2 breaths. 30 compressions, 2 breaths. You do that 5 times before you come and check whether the pulse is there, it's back or not. So you don't do 1, 2. Oh, let's check it. No, it's not. How fast? Okay. So how fast? They say that you should do at least 100 compressions in a minute. Now you understand why you need help. You can't do it by yourself. All by yourself. At least 100 in a minute. So they say 100 to 120. So that means that you do 2 compressions in a second for you to get 120 in a minute. Isn't it? It's quite fast. Okay. So that's how fast you are going. And that one, it doesn't matter whether you're a child or because you know that even children, they have a higher heart rate compared to the adults. So that's how fast you would go. 100 to 120 is what you are doing. So in terms of the compression alone, we say that you need to identify the cardiac arrest early. Start the compressions within 10 seconds of you identifying that there's a cardiac arrest. Okay. Compress deep, push hard, push fast, minimize interruptions. Yes, sir.
So if you're going to do 100 compressions within a minute, what time do you give for the chest to recover?
Right, we'll show it. Yeah. It's not like leaving the entire thing, but we'll show. Just make sure that you come out. When you press, you come out fully. Okay. You don't press, you're down there and press again, you're down there and you press again. Yeah. So we'll go through. So I will show that next. Yeah. So after I show this, we'll all come to our mannequins and we'll go through from beginning till this time. Check for scene safety, responsiveness, calling for help, and going through whether they are breathing, they have a pulse. You go through that. Okay. That's why the mannequins are now crying for you. They say we've been lying here since you have not come to us. Okay, so I come, I check the scene is safe. Okay, check for responsiveness. He's not responding. Okay, I call for help. Kobe, call 193. I call 193. Okay, I come, then I check. Is it breathing? Is not breathing? Is there a pulse? There's none of that. Okay, so I've diagnosed my cardiac arrest, isn't it? Okay. Then I'm come to start my compression. So I identify, put my hand there, the heel of my dominant hand, I put it there. I'm well over the patient, and now I'm going to go. Okay, and I need to count 30. I'll count up to 30, then I stop and give breath. We haven't done the breath, so we'll not do the breath, but I'll count up to 30. Okay, so then I go 1, 2, 3, 4, 5, 6, 7, 8, 9, you need to lock your elbows. So you cannot be doing here, it's locked. Shoulders are well over the patient. And then you go. Okay, that's what you are going to do. So you do 30. Then come and give the breath. We'll come to the breath later. We'll talk about it. So come and give the breath 2. Then come back and do 30. So we one Robbie and Mark. Wow, everything. You get it. So that's how it's supposed to go. And quite a number of times people don't do the compressions well. So it will not yield any results because the high quality. That's about the high quality thing. It's not about it's about doing high quality CPR. Any questions?
So with the ink,
Okay.
okay, so you mentioned that when it's pause, you just help the person breathe.
Yes.
So how do you do
The rescue breath will come to breathing. Now we are just concentrating on C, compression. They'll come to the airway, they'll come to the breathing.
How about the infant? You do the same thing.
So the infant, how do you do it for the infant? The difference thing is, if you have one person, which we say one rescuer, you place them there, 2 fingers. Use 2 fingers to do it, but the same place. So lower half of the stem with 2 fingers, then you do the compressions. Okay. And that one you do 30 compressions, 2 breaths. If you're alone, okay, that's what you do. And then F. If you have 2, then you hold them. They say thumb encircling method. You hold them like this. Your thumb comes to the same lower half of the stem, and use your thumb to do it. Okay. If you have 2, because if you have 1, you can't do this. Then you put them down and come and it will waste time. So if you have 2, then you have time. You alone will be doing this. Someone will be doing the bagging. So if you have 2, that's one will be the thumb encircling. If you have 1, place them like that and you do that so that you can easily go and give the breath. That's what you do for the infant. Yes, sir. Yes. Right. Okay. Alright. So John will pass. He said he has books for you to write. Those of us who don't have books. Some of us we don't like books.
Pass.
Well, once they pass the book, someone is asking a question. Sorry. A player. Okay.
Oh, it's coming. Oh, no. Wait. Take.
The hand is their mouth. Okay, all right.
Sorry. Pen.
So what we are talking about looks like it
Do you have some?
as a vertical way of doing things, whereby you are the only person and you are doing the thing. If you are more, you can tackle the thing at different points at the same time. So, but in any case, you still need to first assess the air before you do anything in the mouth. So say, if there's something in the mouth, you're not going to do anything else in the mouth. You need to bring out any foreign body that is in the mouth before you do it.
Okay, we didn't hear. Just please, we didn't hear that.
Okay, so others are saying they didn't hear. The question was that the player collapsed and they put, the first thing they did was to put something in the mouth. And I was saying that, sorry. Okay. What I'm saying is that usually when you are more, what we are talking about or discussing is look at it if you have one vertical approach of doing it. But if you have more than one person, you can tackle it from different points at the same time. Okay. But it should still be a systematic way of doing it. Okay. Because you don't go to the airway when compression has not started. And the first person comes in, what they are interested in is the airway. The first thing should be, if it's a cardiac arrest, the first thing should be that they start the compression. They identify that there's a cardiac arrest and start the compression before they deal with the mouth. Because the thing is, we are saying that the heart has stopped. The blood sitting in the heart that has just stopped It's already oxygenated. So you want to move that blood around first. You try to deal with the airway. The airways make sure that the airway is patent for you to get in oxygen. That will go and mix with the blood. But the blood sitting there is already oxygenated. Why do you want to waste time to deliver air when that air when that blood sitting in the heart is already oxygenated? That's how come they changed it. Because it didn't make sense if you look at it logically. The person just collapsed. There's blood in the heart. That's already oxygenated. So move that blood around and later come back and give more oxygen so that the next one that counts will now get oxygen. And actually there is even, it's accepted if you're not comfortable outside the hospital to give breath, because if you're outside the hospital, you need to do mouth to mouth if you don't have things like these ones. And if you're not comfortable because of many diseases, you can just do what they call the compression only CPR, where you are just doing compression, not giving any air. It's acceptable. Okay. Because others have said that whilst you do that compression, you allow for the chest to recoil. When there is that negative pressure developing, air passively goes in. It's not as much, but passively some air goes in. Okay. So if you're not comfortable doing mouth to mouth, you can do compression only. So it tells you that the compression is the main thing. The main thing. So they cannot be fidgeting with putting things in their mouth and all that when if the person is cardiac arrest, it's not starting compression.
Can you do CPR for an accident victim?
You can do it if they have a cardiac arrest. Because they can have an accident victim who's not in a cardiac arrest. But if there's a cardiac arrest in a patient who's involved in any trauma, they say, this even will be my statistics, only 1% of them will survive. Cardiac arrest in a trauma patient, only 1% of them survive. Sorry. Why? Because of the causes of the cardiac arrest in trauma patients. So one of them, tension pneumothorax is one of the causes of cardiac arrest in trauma patients. Okay. Cardiac tamponade is the other thing. Okay. So if all these things happen outside the hospital, you might not be able to even diagnose them to be able to reverse them. And until you have resolved it, your CPR will go nowhere. Because the cause of that cardiac arrest is still there. You haven't dealt with it. So you might not be able to get them back. But they also go to cardiac arrest. As we said, every patient will die through cardiac arrest. And every patient will die through cardiac arrest. Every patient will die through cardiac arrest. And you have yeah. Every patient dies through cardiac arrest. Yeah. What you are going to ask a question. Okay.
I said, and on the infant compression, you did not touch on the compression number. Is it half of this or when you are two?
It's the same thing. Compression. Or the 100 to 1 in a minute.
Well, I learned someone that when you are two rescuer, the compression will.
The rate will change. So for an infant and a child, if you are more than one, if you are two or more, the rate of compression to breathing will change, or the ratio changes a bit. So understand it first. Usually the cause of cardiac arrest in infants and children is usually respiratory problems. Hypoxia. Usually they are cause of cardiac arrest. So in terms of resuscitation, they want to give them more breaths than they give adults. So they say that if you are two or more, you do 15 compressions and give 2 breaths. If you are two or more, for an infant and a child, you give 15 compressions, 2 breaths. You know that by the time you are giving 30 compressions, you are giving 4 breaths, isn't it? So you tend to give them a bit more breath than they would give adults, because usually the cause of arrest is hypoxia, respiratory problem. Okay. So let's summarize that bit well for you to understand. For an adult, whether you are 2 or you are 30, the compression is 30 compressions, 2 breaths. Adult, no matter the number, is the same thing. For infants and children, if you are 1, it's still 30. Okay. If you are more than 1, then you do 15 compressions, 2 breaths. So, if the rescuer is 1, whoever you are, 30 to 2 is what we do. If you are more than 1, rescuers. For adults, it's still 30 to 2 that you do. For infant and child, 15 to 2. I hope that is clear now. Sorry. And I come and cycling. If you are 2, that's when you do that. But still, if you are 2, that means that you'll be doing 15 compressions different with that common cycling method. Any questions? So now, let's come and get to our mannequins. How many mannequins do we have?
What about the choke?
We'll come there. Choke will be the last one to talk about. 4, 7, 18. So that means we are more than the number. So some will have their own mannequins. Some of us will pay. Okay. So let's get to our mannequins. We'll go through the C aspect of our resuscitation as a compression. So let's get to our mannequins. Let's get to our mannequins. And be by the side of the mannequin. Because this half mannequin, but if you assume that it's a whole patient, you cannot be standing here, so you'll be kneeling on their stomach. So be by the side of the patient, okay? And you can turn the side that you kneel on the mat. Okay, you can turn the side that you kneel on the mat. Don't kneel on the floor, kneel on the mat.
Okay, me and you will share this one. Okay.
In fact, this one is free. This one came up.
This one is free.
Therefore,
Now we do it together. Is everybody okay? At least 2 to 1. Okay. All right. So you have gone. As you were going, you saw this man. Saw this man. There. There. He's in the middle of the road. You approach, this is the patient. What will you do? Yes, ensure that the scene is safe. The scene is safe. What's the next thing you want to do? You check for responsiveness. Okay. Everybody should check for responsiveness. No, you can check for yes, so you check for responsiveness. If not responding, what is the next thing that you do? You call for help. Call for help. Call for help. You call what number? You call 193. It's busy. Okay, so you call 193. They said they'll be there in 10 minutes. What's the next thing you're going to do? You expose the text. You said that you cannot expose the text. If you can't expose it, why can't you expose the text?
Let's say the person has won the police suits.
Maybe
it's a lady and then she's won
Okay. All right. So, I mean, if that is how difficult it's going to be to that probably the arrest class. That there's no chest movement or anything like that. But you can do it. You can start your compressions. Okay. When you get to the AED, then you understand why you need, because the AED you need a bare chest to put the thing on. Okay, isn't it? So eventually you will need a bare chest. So I mean, at this point, maybe you can go ahead. You can go ahead, but eventually you need a bare chest.
Sometimes people wear things under their shirts, so if you don't clear the chest, you may end up
Like the crucifix you have there.
hurting the patient. Because
Right.
some people wear this rings and chains and
Right,
other things
right,
like that,
right,
appointed.
right,
So if you
right.
don't clear it, you may end up
If
hurting
the,
the
look at
patient.
the number of minutes to take you to
Oh,
clear.
but accident only
Yeah,
can.
Yeah, so if you have shears, if you have trauma shears, you can cut. Or cut in there, and then you found So I mean that's not a bother to us at all. It's about the fact that you may not even have the trauma shears at that point. That's the only thing. But you can rip things apart to rip it. Rip it. Let's go.
So, how will you handle a patient with pacemaker?
Right. You go through the same things.
The same thing.
Yeah, you go through the same things. Yeah, for the pacemaker, you go through the same things. When it comes to the AED, that's when you ensure that you don't place it on where the thing is attached and stuff.
Okay.
But other than that, all right. So you check for responsiveness, and your patient is not responding, and you have called for help. They are coming. What's the next thing you do?
Check.
I'm going to check for the breathing and the pulse.
Check it on this.
So check for the breathing and the pulse.
So you do this.
He is not breathing, and there's no pulse.
Start CPR.
But one thing that we didn't address is how do you check for the carotid pulse? How do you check for it? How do you check for it? So they say that your two fingers come to the midline, then slide laterally. Okay, the group that the trigger mixed with the muscles there, you press,
Can feel it.
and you should be able to feel the pulse. Okay, so that's how you check for it. Midline, slide laterally, the group that is there, and you check for the pulse. Okay, and check for this should not. I want you to learn it too, because and you're going to happen. And remember, we said 10 seconds. So happy that you're here on you. So actually, they've said that for lay people, they should not bother themselves checking. They should check for breathing. They don't see any breathing. They should go ahead and start compressing. Because I'm happy now. How do they check for? Even the health people are struggling. Okay. So they've kind of removed that from it. They don't emphasize it so much. Okay. So you check. There's no pulse. They are not breathing. What are you doing? Yes, that's compression. Okay.
Dominant heel.
Okay.
Where's
So
the
let's
dominant from?
put our dominant heel in the lower half of the sternum and our elbow locked, shoulder well over the patient. Exactly. So for the other thing is that they say you can use only one hand. So the heel, you can just use your heel, only one. Dominant heel actually. The dominant heel, that's what you use. Yeah, you can use that. Depending on how big that fly is. Because I collect you on it, you'll be away deep before you carry a pen. Just how. Okay, so now your dominant heel is over the lower half of the sternum. Your elbow is locked. And we are about to start our compression. And I'm
It's already.
and you do it. I didn't mind.
Yeah, already.
Okay, so are you ready? Yes. Everybody ready? Yes. So we're going to go.
When you press,
that goes.
let it.
Stay alive. Stay alive. That's the rhythm. So that's how you go. So we're about to go. We are start out our Okay, so your hand dominant heel, the lower half of the sternum, elbow well locked, shoulders over the patient. Shall we go? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. This is just the beginning. This is just the beginning. Okay, we are going again. We are going next time, so we are going next
This
time.
one too, they have a you position.
I'll come out and see where your dominant heel is, whether it's really on the sternum, the lower half of the sternum. Okay.
Okay.
All right. So your dominant heel over the lower half of the sternum, elbow lock, shoulders roll over the patient. Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 1, 2, 3, 4, 5, 6, 7, 8, 9, 30. Last round. Okay. Abdominal heel on the lower half of the sternum. Elbow lock. Shoulder over. Well over the patient. Now we go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13,
You kill the person.
Those who didn't do it, maybe it's your time to do it.
You kill the person.
Those who didn't, so you can swap, so that those who didn't do it. But if you're alone, then you are done, you can sit down. Yeah. Those who didn't do it, like.
You die, you go away from my force. You
That is there.
The one that I do, the one that we were doing, there was something attached to the patient. So you see your rate, whether you are going fast or slow. And if you are pressing too much, it will tell you that you are pressing on the patient. So you have to let it release, but you have to go with the rhythm. My hand wasn't bouncing, and I'm not bouncing.
Your shoulder roll over the
Like this.
Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. And most of you need to go deeper than how deep you are going. You need to go deeper. And you will not see black. Okay? All right. Okay, so we can resume our seats. So all this that we have done is just for the heart. It's the cardiac resuscitation that we are doing.
You do what? It was clear.
That is then choke.
Also here.
And it is the
Also
major
here.
one. It is the major one because as I said, it's the most important. The compression is the main thing. The whole CPR thing that you're doing, the compression. If you don't do it well, you're wasting your time. If you don't do it well, you're wasting your time. It's all or none. They are doing it well or not at all. Just declare that we now have to watch that to do it or not do it well. Okay, so you've done the 30 compressions, you need to give the break. Okay, but before you give the breath, you must ensure that the airway is patent. Because you have to give air and must go through a pathway into the lungs. So if that pathway is blocked, the air is going nowhere. So you must ensure that the airway is patent. And that's about the airway. And what are some of the things that you can do to make the airway patent? What are some of the things to open the airway? Ensure that it's patent. That's how it's sorry. Open the mouth Yes, obviously, you need to open the mouth to give. Yes.
Tilt the head.
Sorry.
Tilt the head.
Tilt the head is also one thing, isn't it? The chin. Okay, good. So you do the head tilt chin lift maneuver. Head tilt chin lift maneuver. It's one of the things that you can do to open the airway. And the other thing that you can do to open the airway, which they talk about, is jaw thrust. Jaw thrust. So to open the airway, you do the head tilt and chin lift. How do you do that? So again, this is our patient, okay? With two fingers, place it the mandible, okay, the chin, basically. You do that. That's lifting it, isn't it? That would be the chin lift. But with your palm, you put it on the forehead and you move the head. That would be a head tilt. So you do this. I don't see why they ask us to do the chin lift, because once you do this, the chin lifts. But I say you should do head tilt, chin lift. So you do that and you do that. Basically, you are opening the airway, because the airway, it goes like this and this way. So it goes, the mouth goes like this, and then it continues like that. If it's like that, it's kind of bent. You want to bring it, you want to make it straighter a bit. Okay, so once you move the neck, it becomes more straighter a bit, so that there's free flow of the oxygen or air going through, rather than it going through there and there. The flow is not the best if it's that way. So you do that to align the airway very well. Okay, that's basically what you're doing. Okay. But if you're going to bag, how do you do that? How do you elicit that kind of maneuver? Okay, and that's the question. But in terms of the airway, the two things that we need to talk about is the head tilt chin lift and then the jaw thrust. The jaw thrust, we don't usually use it that much when we are doing the bagging. Okay, but basically you put your fingers. So when you're doing that, when you're doing a chin lift, you cannot be by the side. You need to be by the head end of the patient to be able to do that. So you put your finger behind the mandible. You see the jaw is here and the angle is there. You go behind it and you move it forward. Okay, basically the tongue is attached to the base of the mandible. So once you move the mandible forward, the jaw, lower jaw forward, the tongue is moved away, because when they are unconscious or unresponsive, the tone is also going down. So the tongue falls back and obstructs the airway. So if you are going to give air, the tongue is obstructing. You need to move the tongue away from the oropharynx so that it doesn't block it. Okay, so that's basically what you're doing by trying to move the mandible forward. Okay, so once you move it forward, the tongue is displaced off, obstructing the airway. But as I said, we don't really use it that much when it comes to when we're doing the compressions and we're opening the airway. What you do mostly is the head tilt, chin lift maneuver. Okay. That's about the airway. The airway is very short.
Thank God.
You can go.
Thank God.
That was very short. So we'll go on to the breathing. Any questions on the airway? We need to open the airway. The other thing that I probably didn't say is that first look inside the airway if there's anything obstructing the airway. Because some people will have a dentures that may fall back, you need to bring it out. Some people will have secretions in their airway. If you're in a hospital, you can easily suction that. If you are not, and you're out there, you can put your hand in the button and scoop it. Maybe you can scoop it. Okay. If there is a foreign body in the mouth that you can see with your eyes, you can do what they call a finger sweep. Okay, you go bypass it, hook it, and bring it out. You can bring it out. Okay. If you don't see it, don't put your finger in the mouth. Okay, because you may push it further down. So you must see it then you can do the finger sweep. Without seeing, don't put the finger in the mouth. Okay. So, in also the construction, you can do all those things and you clear the airway. Okay, so you first look, sure that there are secretions, there are not secretions, suction. Once you are done with that, you can do your head to chin lift, open the airway, and then you can give your breath now. So if there are no questions on the airway, move on to giving the breath. Okay, sorry, 2 questions.
So just a quick one. The jaw grafts, you said it's not normally used practically.
Yes.
Is there any reason?
No, when you are bagging like this, so the indication for using that is when you think that there's a cervical spine injury, that you don't want to be moving their neck. Because when you do that job, you're not really moving their neck. So that's when you want to use that maneuver. Usually most of the patients, they are not like injured patients. They are just medical cases that are having their cardiac arrest. So we don't usually use that. Because it's a bit cumbersome doing that with a bag and all.
For the chin lift, to what extent should you lift the chin, or to all the way up, or?
Oh, you go all the way. I mean,
All the way
once there's no neck injury, you can go all the way
Okay.
to open it, because I think the further away you go, the more straighter it becomes. Yeah, but at some point it will stop, isn't it? At some point you will go further.
And also on the C, if you're doing the CPR, let's say a lot of people are doing the CPR, and they're done it for about an hour. At what point do you stop doing the CPR?
Right. How
When the
long do you
patient-
stop? It depends on what eventually it tells that you are managing. When you are doing the CPR, not just doing it in the vacuum, you still think about the reversible causes of the cardiac arrest that this patient may have. Okay, and that's more into ACLS. This BLSO, we don't talk so much about it, but so when you are doing it, so at times they bring, according to the triage system that we use, any patient who come with an arrest scores red, and you need to resuscitate that patient. So maybe someone will come with VIH, but once they come with VIH, that means that they don't have cardiac arrest. If they have a cardiac arrest, they don't have a pulse. So we need to start CPR. So we'll start. Usually when I'm around, we'll start it. But then we'll look for the cause of the arrest, whether there's a reversible cause of the arrest for us to correct and see whether the person will get the heart coming back. And the reversible cause of cardiac arrest have been divided into what they call the H's and the T's. Okay, H's and T's. So the H for adult is hypovolemia. That is first. Then they come to hypoxia. Then they come to hypo or hyperkalemia. Then they talk about hypotension, hypoglycemia, hydrogen ions, that's acidosis. Those are the things that they look at for the H. And the T's, they talk about the tension pneumothorax, the tamponade, that's cardiac tamponade. They talk about toxins, so overdose of medications and stuff like that. Then they talk about thromboembolism, that's P or MI, myocardial infarction or P. Okay, so those are the things that when you are doing the CPR, you are thinking about. So this patient who has come, let's check the RBS. They are checking the RBS. Let's get a line. Let's start fluid because of hypovolemia. Let's give oxygen. We are giving oxygen. Okay. Let's take blood quickly. Luckily, we have an ABG machine. I have blood gas. So once I take within 2 minutes, I will know what the potassium is. So I will know the hyper or hypokalemia. So then I can deal with it. The IBG will give me the acidosis rate, hydrogen ions. If there's acidosis, the pH is down, is low. So within the 10 minutes, I will know what it is that I'm dealing with and what I need to correct. Okay, I have an ultrasound machine. I'll look to see whether there's a pneumothorax or there's a cardiac tamponade. I will see that. If there's a P, there are signs on an ultrasound that you can look for. Okay, you may see that on doing the ultrasound. So with my ultrasound with the ABG, I will know a lot of things. The reversible cause of cardiac, I will know quite a lot of that. And within 20 minutes, if I don't have a pulse and I've gone through and know that it's not any of these things, or it's any of them I've corrected and it's still not coming back, I'm done. So within 30 minutes, I'm done. But they say that, if someone has hypothermia, which we don't really see around that much, and in this winter, for instance, Obi might make I say UK, they are in serious trouble in terms of this eating and stuff like that, economy, so hypothermia is a big thing. But they say that the patient is not dead until warm and dead. So if the patient comes with hypothermia, you need to do the resuscitation and warm them along the line until they are warm and their heart is not bad before you say that they are dead.
Oish.
So that one can go on for like 1 hour, 1.5 hours. And if a patient comes with, say, a P, you confirm that this patient had a P, it's done CTP, that confirmed P, and the patient goes into a cardiac arrest, that means that then you'll be managing the patient as a massive P. And with that, you need to give thrombolysis as part of your resuscitation, alteplase. Alteplase in Ghana, the last we checked, was like 26,000. So if I'm giving alteplase, I need to ensure that the onset of action of alteplase has started and has completed. Before I will say that I've given this patient 20,000 and I do 2 minutes and I stop. Come on. So it depends.
Okay.
Basically, what I want to say is that it depends.
Okay.
If I'm the only person doing the CPR and I'm tired, I'm tired. I don't continue. I'll stop. I'll stop. So that's why it depends. The scenarios, it depends. But generally, around 20-30 minutes, we have decided and we are either stopping or something. But other than that, it will depend. All right. Any other question? All right. So you have opened the airway. The airway is now hitting, and now you need to give your breath. You need to give the breath. Now the breath, it depends on where you find yourself and what you can do. As we started saying earlier on, if you are home, you don't have ambu bag or anything like that, you may need to do mouth to mouth. If the person is your spouse or your child, is an animal. If the person is somebody on the street, you don't know the person. Yeah? Hep B, Hep C, HIV, all that will be crossing your mind. You go and do mouth to mouth.
Oh.
But that is what I mean. That's one of the ways of giving the breath. And I ask that we breathe in and we breathe out carbon dioxide. Why are you going to give your carbon dioxide to this patient? Why? What do you want? Why do you breathe into another person? How do you do it? Or why is it possible that you can still do that? Sorry.
It's possible when you're bringing out, it's not entirely carbon dioxide. There's some oxygen in there that's
Right. I agree with you. So though we say that we bring out carbon dioxide, that some of the air that we bring out is also oxygen. The reason is atmospheric oxygen is how much? 21%, isn't it? And nitrogen is about around 78, isn't it? So we take in that 21%. We use only 4% of it. So what comes out also contains oxygen. Okay. We have what we call the dead space. When your airway, when you breathe in, not everything gets into your lungs for it to be used, isn't it? The bronchus and the trachea, there's still air in there, and all those oxygen, it's not taxed, it's not used. And when you're breathing out, they are the ones that will come out first, isn't it? The ones in your nose and in your oropharynx, they are the ones that will come out first. And they would contain some oxygen. And that's how come you can breathe into another person. So you have taken in 21%, you've used 4%, it's not how what percentage? 17 thereabout. You can breathe 17 and you also use 4%. And you can also give isn't it? So that's how come you can breathe into somebody for them to also get oxygen. So that is how. Okay. So how do you do it? I don't have they bring this polythene so that I can use it, but they don't have it. But you need to open the mouth, isn't it? You need to close the nostril because if I blow through here, it will come from here. If this is not closed, okay. So I will pinch the nostril. I use this border of my hand to do my hair tilt. You get it? So I do that, hold it this way and do that. And use this other one to open the mouth. Then I take in a deep breath by myself, okay? Then I would wrap my mouth around the mouth like that, and I'll blow into this patient, and they're able to get the oxygen they need. Okay, so that's basically how we do. It's the same 2 breaths. The same. So you take it, you put your mouth around it, you take the breath. 1, you do it again, you take in then 2. And what you want to see is the chest rising. That's all that you want to see. Just want to see a chest rise. Okay, that's what you do. So that's one way of giving the breath. Another way of giving the breath is to use what they call the pocket mask. Again, there's this one here. But it looks just like this one. Okay, there's some valve component over here that prevents any secretions from coming from the patient into your mouth. Yeah, so now as pocket mask, it can go into your pocket. So some people walk around with that in their pocket. Expecting.
Emergency.
Yeah, high expectation. Yeah. Some people have it in their cars, actually, it's in their cars. Not in their pocket, in their cars. So that if they meet something like that, they can easily reach out for it and they use it. The pocket mask. Yeah. So that's the second thing that you can use if you're outside. But if you come to the hospital, most likely you would have this. You have the ambu bag. So it's called the bag. There's a valve component over here. So bag, valve, mask device. The bag is a valve, there's a mask device. But this company that makes it ambu, so we can call it ambu bag. But not all of them are made from ambu, or not all of them are made by ambu. So the appropriate word would be bag, valve, mask device. Okay, so this is it. How do you use it? If you see there is a reservoir bag here, there's an oxygen port over here that you connect to the oxygen. Okay, you need to connect it to oxygen. Ensure that this one is inflated. Okay, because the oxygen that you are going to give, it's not the one coming straight, it's the one that is reserved here. That's the one that you deliver. So ensure that this one is inflated if it's being used. Okay, so this is the device. This mask, if you look at it, is tapered like this. It's not uniform, it's not the same thing. It's shaped in a particular way. Okay, it's tapered at this point and brought that down here. So how you place it is that this part goes to the bridge of the nose. And it should be able to cover, the appropriate size is that it should be able to cover the nose and the mouth. It cannot just cover the nose. It cannot just cover the mouth. Okay, so if you look at this, it's small. This one is small. It's very small. If I use this small one on this adult, it will be a nose mask. It will be a nose mask. It will be a face mask. Okay, so that will be an inappropriate mask. It's too small. So this one, it covers the nose and the mouth. Okay. Again, when you're using this one, you cannot be by the side. It's difficult to be by the side to use it. So you need to be at the head end of the patient. Okay. And the technique of holding it in place is called the C and E clamp. The C. So with the index finger and the thumb, you form a C. Okay. It is that which will go on the mask. Okay. You hold the mask like that. And these 3 fingers, which will be the E, will hold the mandible into it. And with that, you will be able to do your air tilt and chinlet with that. So it goes like that, okay? And then I do that. So this one holds it in place or hold it to the face. And I use this tray to pull the mandible into it. Yeah, the C&E technique. And you need to do that well so that there's a complete seal. Other than that, when you give the air, it will leak around it. And if it leaks, you won't get the air going inside and chest will not rise. Okay, so that's how you hold it in place. And the fingers are on the mandible, not in the midline, because once you leave the mandible and go to the midline, you'll be in the soft tissue and you'll be obstructing the airway. So you don't go to the midline, you hold the mandible. So it's the bone that you want to hold. Okay, so that's what you do. Okay. And you need to extend, with that you need to extend the neck, open the airway. If you don't do that, you give your air, it won't go. Okay, so once you've done that, I mean obviously normally it comes complete like that. So to come like that. Usually if it's like that, it's difficult to use. So I turn this one this way. Okay, so it's like this, and then I go like that. Okay, then I try to ventilate. You see that the chest is rising.
Oh wow.
You see the chest rising. If I don't do it, I don't extend the neck, and the neck is here like that, and I do it. I'm giving as much as possible. Chest is not rising. So the difference is very important. If you don't extend the neck, you'll be there. So people will be there, they are bagging, but they are bagging nothing. No air goes inside. Oh, all right. So that is about opening the airway and giving the breath. Okay. So we'll come back to our mannequins. Then hopefully.
Sorry.
Yes, sir.
So if the air doesn't go inside, should you continue or you should try?
Sorry.
If you are giving the breath and doesn't go, you see that it's leaking.
Right.
Should you continue with whatever the true breath, or should make sure that the patient has the chest is rising?
Okay. So at times it can leak and some of it will go in and chest will rise.
Okay.
Stop. What you want to see is the chest rising. That's what you want to see. But if I did that too and it's not rising, I'm not going to spend my whole time trying to let the chest rise. As we said, compression is the most important thing.
Okay.
So you stop and do your compression and think about how to improve
On it.
that ventilation skill or maneuver. Okay. So that the next round you can do it better.
Okay.
You will not spend 5 minutes trying to see whether the chest will rise and the chest will rise and you are there without any compression. Because all this time without doing the compression, there's no circulation. Okay, you are not circulating the blood. So that will not be helpful to do that. Now, what they say about this giving breaths, and we are just saying, just ensure that the chest is rising. You don't want to give so much air into the patient. You just give enough. If you give too much, what will happen is that, you know, the airway and then the esophagus at the top, they all have the same entry point at some point up there. So the air you are giving, you're not just sending it into the lungs. You may send some of it into the stomach. And usually when you hyperventilate or you give too much, that's when you have a lot of it going into the stomach as well. Now you send so much air into the stomach pressure would increase. And what they call the lower esophageal sphincter, which is at the end of the esophagus, will now open because the pressure in the stomach is more than the pressure that is keeping it closed. It will open. Then the content of the stomach will come out. Then they would aspirate.
Yes.
So the aspiration that has come on top of this patient's throat is you who cause something. Okay, because you are giving too much air that's getting into the stomach, causing the sphincter to open and then to come. Already the patient ventilation is a problem, and you put in stomach content in there as well. Come on, finish up. That is one. That is one reason why you don't want to give a lot of air. The other reason is that when you give a lot of air, the intrathoracic pressure, the pressure in the thorax, also increases because there's so much air in there. So it becomes very tense in the thorax. To increase intrathoracic pressure. Now, when it comes to flow, you must have a pressure gradient. There should be one that is high and one that is low. When blood is flowing from your legs, your stomach into your heart, there should be a pressure gradient. The pressure in the chest should be lower than where it's coming from. Okay. So if you increase so much intrathoracic pressure, and the pressure becomes equal, and your venous return to the heart also now becomes impaired, decreased. Already you are in cardiac arrest, you want blood coming to your heart. Intrathoracic pressure has increased, and blood coming to your heart decreases. So your cardiac output also decreases. And so you don't perfuse the tissues well. So in all intents and purposes, giving too much air is not good. Yeah. But if you understand what is happening, then you know what to do, isn't that? Yes. If you understand what is happening.
That's I'm personally.
So you not give too much. You just give enough to keep chest right. That's all that is. Any questions on the grades?
So when we apply the max, use the left hand.
So you can do it any ways. However you feel comfortable to hold. Yeah. You can. I usually prefer to hold it in my left and I use the right to back because my left cannot really do the bagging well. So however you are comfortable, make sure that there's a good seal and when the bag it doesn't leak and you get it down chest right. Any other question? Okay, so shall we resume? Come back. Yeah, whilst you're asking.
The giving the breath, you said 2, right?
Yes, 2 breaths.
So, can you give it?
So within a second. So.
Oh, okay.
Yeah. So you go. Papa. 2 breaths. Okay.
So I'll be here.
Be at the head. So turn the mannequin so that the head is facing you. Yeah, turn the mannequin. Yeah. Now I'm around to see whether you want the chest to rise or not.
No.
How you hold it. And so once you hold, remember to extend the neck. Okay, extend the neck. Other than that, you will not get it. So do it and let's see.
No. When you remove that hands, you see it. Nice one. It's too much. Turn this way. No, come this way.
That's how you do it.
The leak. No, that's why he's saying that. Not all of them will enter like that.
I think you should tilt it one
Right side. So, sorry.
Like,
So,
yes.
So because of what let me talk about when you have if you have opportunity to have 2 people just managing that airway. Okay, you can do hold the mask in place. Let me show you this one. So one person will hold the mask in place, another person will do the bagging. Okay, so if you have 2, with one hand you do it this way on this side, and the other one will hold it here like this side on this, and then you extend it. So if you are pulling, it's better that way. The seal becomes better, and then that one will back. So then it should be the bagging. So you do the bagging, and you can see the chest right there. Okay. So So in the hospital, for instance, we can use what they call the oropharyngeal which is inside the mouth. I don't have it. Go ahead. So the chest rises.
Yeah, very good. Yes.
Okay. All right.
I was
So
very surprised.
you got two. You have to use the 2 hands to hold it in. Yeah. Yeah. Press it down. Yeah. Yeah. That's basically it. Yeah, so you see, once you start extending it, you've done it. Yeah, you've done it. Once you extend the neck, you've done it. You've done it. Yeah. You need to keep that because you need to keep it this way. Then you do it. You see how you've done it. How do you do it here?
So do it, Salamis. Okay. Hey, I'm good though.
That's how you do it.
Make it one again.
Okay. Okay, try to do it again. Let's see.
No, the chest wasn't rising.
You kill him.
You see, the thing is, how, like they said, the return of the blood to the heart is very important. So if it's recalled, yeah, you were talking. Yeah, if it recalls, the heart can be filled with blood and you can pump it again. So if it doesn't really recall, then you do it. There wouldn't be enough perfusion. Let's go. Oh, the guy is there. You couldn't go 30 again.
I know say you don't go make up.
It's not easy. They should have gotten that in the detector there. That one, it helps me. It will be much easier. If you know you're going fast, it will tell you you're going fast, then you slow down.
I want to do it again.